Hello, and welcome to the Chest Journal's Editor Highlights podcast. Each month, Chest Editor-in-Chief Dr. Peter Mazzone highlights key articles from the current issue of the journal to help clinicians stay informed about new research in the fields of pulmonary, critical care, and sleep medicine. To introduce this month's episode, here is Dr. Peter Mazzone.
Thank you for tuning in to the Editor's Highlight podcast for the March 2026 issue of the journal Chest. We have a great lineup of diverse content in this month's issue. Over the next 15 minutes or so, I'll provide a brief overview of key manuscripts published in each of our content areas. In our asthma section this month, you will find a Chest narrative review on asthma and pregnancy. Our chest infections content area is up next. The role of adjunctive corticosteroids in non-HIV associated pneumocystis pneumonia is unclear. In this issue, Pulsifer and colleagues report findings from a multi-center retrospective cohort analysis of 375 non-HIV immunocompromised adults who were hospitalized with proven or probable pneumocystis pneumonia, 351 of whom, or around 93.6%, received corticosteroids. The study was designed to determine if there is a dose-response relationship between adjunctive corticosteroids and outcomes in non-HIV immunocompromised adults with pneumocystis pneumonia who were requiring supplemental oxygen. 56% of those included in the study required ICU care, and 44% died within 90 days. Greater cumulative corticosteroid dose was associated with increased risk of 90-day mortality, with a hazard ratio of 1.01 per 100 milligram prednisone equivalent. Corticosteroid exposure was not associated with risk of intubation or faster liberation from advanced respiratory support. These findings suggest that higher cumulative corticosteroid exposure beyond doses of trial-tested regimens should be approached with caution. Completing this section is a research letter that assesses the association between incident non-tuberculous mycobacterial isolation and antibiotic exposure in patients with bronchiectasis. Our COPD section is next. Clinical tools for predicting major adverse cardiovascular events in patients with COPD have underperformed. In this issue, Torres and colleagues report findings from an observational cohort of 529 patients with COPD who underwent a chest CT scan, had clinical, functional, and laboratory testing, 24% of whom had a major adverse cardiovascular event during 98 months of follow-up. The study was designed to determine if a combination of cardiovascular risk score and coronary artery calcium score improves risk assessment for major adverse cardiovascular events in people with COPD. Using thresholds of cardiovascular risk score calculation of 10% and coronary artery calcium score of 3, patients were divided into 4 groups: low-low, high-low, low-high, and high-high for the 2 scores. The hazard ratio for major adverse cardiovascular events for Group 4, which was high-high, was 7.6. Group 3 was 3.1, Group 2, 2.6, compared to the low-low group. The area under the curves for predicting major adverse cardiovascular events were 0.72 for the combination score, 0.69 for the cardiovascular risk score alone, and 0.66 for the coronary artery calcium score alone. These findings suggest that the cardiovascular risk score and coronary artery calcium score provide complementary risk stratification in people with COPD. Completing this section is a chest narrative review on small airways disease in people with COPD. Next is our critical care content area. Atelectasis, mainly caused by secretion accumulation, frequently occurs in people with impaired consciousness who are receiving invasive mechanical ventilation. In this issue, Hugh and colleagues report findings from a multi-center, single-blind, randomized controlled trial that included 80 people from 11 hospitals in China. The study was designed to determine if continuous high-frequency oscillation therapy improves lung aeration and reduces atelectasis in adults with impaired consciousness, judged by a Glasgow Coma Scale score of less than or equal to 8, who were mechanically ventilated. On day 5, the decrease in non-aerated lung tissue from day 1 to day 5, measured by a CT scan, was greater in the continuous high-frequency oscillation therapy group, with a fall of 51.3% compared to 37.6% in the control group. The continuous high-frequency oscillation group also had a higher number of ventilator-free days, a lower clinical pulmonary infection score, and a shorter ICU stay. This study showed that 5 days of continuous high-frequency oscillation treatment significantly reduces non-aerated lung tissue in patients with impaired consciousness who are mechanically ventilated. Completing this section is an original research article that assesses timely primary care follow-up after hospitalization for pediatric critical illness. On to our diffuse lung disease section. The impact of dietary interventions on weight loss and prognosis in patients with fibrotic interstitial lung disease is unknown. In this issue, Kahai and colleagues report findings from a pilot randomized controlled trial in which patients with fibrotic interstitial lung disease experiencing low weight or weight loss were randomized to either a 12-week specialist dietary intervention or were provided with a dietary information sheet. The study was designed to determine the feasibility of a randomized controlled trial of specialist dietary intervention in fibrotic interstitial lung disease with an exploratory outcome of weight change from baseline. 40 of 128 screened patients were randomized over 7 months, and all 40 completed the study. 8 of 19, or 42%, in the intervention arm, and 1 of 21, or 4.8%, in the control arm, gained at least 1 kilogram at 12 weeks. The odds ratio was 14.2 for the specialist dietary intervention. The estimated rate of weight change from weeks 4 to 12 was a loss of 0.25 kilograms per month in the control arm and a gain of 0.4 kilograms per month in the intervention arm. These findings suggest that a definitive multicenter randomized controlled trial is feasible and warranted. Also in this section is an original research article exploring international stakeholder engagement on clinical care and research for sleep assessment and nocturnal hypoxia in pulmonary fibrosis, and a chest narrative review on the role of MRI imaging in interstitial lung diseases. Next is our education and clinical practice content area. Empirical evidence about the association of olfaction with lung health is lacking. In this issue, Ding and colleagues report findings from a study of 1,951 participants from the Health, Aging, and Body Composition study who had completed the 12-item brief smell identification test and spirometry. The study was designed to determine if poor olfaction is associated with lower pulmonary function in older adults. Participants with poor olfaction had lower FEV1 and FVC at year 5, 8, and 10 clinical visits. At year 5, compared to those with good olfaction, FEV1 was 44 mils lower in those with moderate olfaction and 63.5 mils lower in those with poor olfaction. Olfaction was not associated with the FEV1 to FVC ratio. These findings suggest that poor olfaction is associated with worse pulmonary function in older adults, calling for confirmation and assessment of potential mechanisms. Also in this section is a longitudinal analysis of lung function changes across the menopausal transition and an assessment of gastroesophageal balloon tamponade simulation-based mastery learning curriculum for critical care fellows. Completing this section is a chest narrative review on the mitral valve and the lungs. Our pulmonary vascular content area is next. Growth differentiation factor 15 has been reported to be associated with the prognosis of people with pulmonary arterial hypertension. In this issue, Wang and colleagues report findings from a nationwide, multi-center retrospective study of 435 patients with pulmonary arterial hypertension, designed to determine if the addition of growth differentiation factor 15 improves the performance of existing prediction models for pulmonary arterial hypertension. Elevated levels of GDF-15 were associated with an increased risk of mortality, a hazard ratio of 1.68 in the discovery cohort and 1.98 in the validation cohort. A risk model that incorporated GDF-15 and was based on the Compara model demonstrated improved discrimination for mortality prediction and enhanced fit, with an increase in the C-index from 0.743 to 0.767 in the discovery cohort and 0.658 to 0.687 in the validation cohort. These findings show that GDF-15 may improve the predictive effects of existing pulmonary arterial hypertension all-cause mortality risk assessment strategies. Also in this section is an original research article that evaluates a non-invasive model to predict exercise hemodynamics in patients with chronic thromboembolic pulmonary disease with exercise pulmonary hypertension, and a research letter that reports on the development of pericardial effusions with the use of sotatercept. Next is our sleep medicine content area. The impact of heart failure on in-hospital outcomes in patients with or at risk for obesity hypoventilation syndrome is unclear. In this issue, Kaw and colleagues aim to determine the outcome of patients with obesity hypoventilation syndrome who experience left heart failure in over 72,000 patients hospitalized for obesity hypoventilation syndrome from the national inpatient sample. 58.8% of patients had an underlying diagnosis of heart failure, and 26.3% were discharged with heart failure as a primary diagnosis. Those with obesity hypoventilation syndrome and heart failure were older, more frequently white, had a longer length of stay, and a need for non-invasive ventilation, mechanical ventilation, and non-invasive ventilation plus mechanical ventilation. They had a lower likelihood of discharge to home, had more in-hospital deaths, and more frequent adverse cardiovascular outcomes. When non-invasive ventilation and mechanical ventilation were required, there was a higher inpatient mortality, more acute kidney injury, and more major adverse cardiovascular events. These findings identify comorbid heart failure frequently accompanying obesity hypoventilation syndrome and associated with worse outcomes. Also in this section is a research letter that explores hypoglossal nerve stimulation in the context of non-continuous positive airway pressure therapy in patients with obstructive sleep apnea, and a chest narrative review on the association of obstructive sleep apnea with reproductive aging and screening challenges in women. Next is our thoracic oncology content area. As cannabis use increases globally, particularly among younger individuals, understanding its impact on lung cancer is critical. In this issue, Prader and colleagues report findings from a multi-center prospective study of 150 patients aged less than 60 who were consecutively diagnosed with primary lung cancer. The study was designed to assess the impact of dual cannabis and tobacco smoking in young patients with lung cancer. 39% of the patients smoked both cannabis and tobacco. This group had similar hair cotinine concentrations and cigarette pack years compared to those who smoked tobacco only. Compared with tobacco smoking only, dual cannabis and tobacco smoke users were younger, more often reported chest pain at diagnosis, had higher rates of aggressive lung cancers, more emphysema, and lower gas diffusing capacity. These findings suggest that dual cannabis and tobacco smoking is prevalent in young patients with lung cancer and is associated with distinct clinical patterns, including a higher incidence of emphysema and aggressive tumor types. Several other original research articles appear in this section. The first is an evaluation of tension physiology in predicting outcomes with pleuromanometry in pneumothorax. The second is a UK biobank study that assesses lung cancer risk in preserved ratio impaired spirometry and airway obstruction. Next is an evaluation of long-term major respiratory mortality among 5-year survivors of adolescent and young adult cancer. And finally, completing the section, a national evaluation of intercostal chest drain removal strategies. I encourage you to read our commentary series, where you will find thoughtful pieces on clarification of diagnostic yield and bronchoscopy research, and the integration of tumor biology with anatomy as the future of lung cancer staging. And our humanities series, where you will find 2 exhalations pieces, the first titled Non-Perel, The Song Within, and the second, The Note Taker. Finally, please review our case series publications for the month, which provide novel and educational cases to help improve your clinical skills. I hope you enjoy reading all of the high-quality content available in this month's issue of Chest. As always, I'm grateful to the authors of this work, the reviewers who volunteered their time to improve the quality of these manuscripts, and to our editorial board for guiding everything that we do. Until next month, I hope you enjoy the March issue.
Thanks for listening to the Chest Journal's Editor Highlights podcast. You can find the articles mentioned in this podcast and more on chestjournal.org. And if you're looking for more context and commentary on articles in the current issue, please check out the original Chest Journal podcast, which features in-depth discussions with the authors themselves. We'll be back again with more Editor's Highlights next month.